I worked together with my coworker Cassidy, who's the adult educator, to create this PowerPoint. There's going to be some things that are UMC specific, but I feel like they're kind of important whenever you're looking at different DKA protocols and the changes in adults and P. So we'll jump right in. So some general diabetes pathology. The body is made to break down food into glucose. So as the blood sugar rises, the pancreas is supposed to secrete
Jamie.
insulin. Yeah.
I'm so sorry to interrupt you. We can't see the presentation if you have it pulled up. Oh, you can't?
Oh.
Oh, it's a me issue. Okay, I'm so sorry. Proceed. Okay. Go right ahead.
You can see it, or I reshared it. Can everybody see it? Okay, perfect. Thank you for the chat. Okay, so when your blood sugar rises, the pancreas is supposed to release insulin, which allows glucose into the cells, and that's what's used as energy. When diabetes occurs, then the body either can't use the insulin or there's not enough insulin to combat the rising sugar. This can cause problems with your heart, vision, kidneys. So it's one reason it's really important to treat it ahead of time. Regarding type 2 diabetes, it's common in both adults and rapidly becoming more common in children. There's many risk factors, but lack of exercise, genetics, and obesity are the top few. In type 2 diabetes, the pancreas does produce insulin, but not enough to meet the glucose demands of the body. So as the body has an increased sugar, then it can't secrete the amount of insulin that's needed. So the cells become resistant. And that's when those terms like insulin resistance come into play. Symptoms of type 2 diabetes are a little bit different than type 1. Sometimes children and adults are completely asymptomatic. They'll have the elevated blood sugars, but you'll start to see skin changes, that darkening color around the neck and collarbones. Sometimes you can see it in the underarm area as well. They have slow wound healing, increased weight gain, an increased appetite, some dehydration. These are the random fasting and 2-hour blood sugars, the hemoglobin A1C, and then some numbers for symptomatic. This is a chart of acceptable children's blood sugar levels. This is decently like what an adult would be, but it's a little bit more refined. And as you can see, in the younger children, the sugar is a little bit higher because they just need more sugar demand being a child. With type 1 diabetes, this is the most common type of diabetes in kids. This is not related to weight or exercise. There's nothing they can do to prevent them from having type 1. So it's genetic or autoimmune. Sometimes children go through a viral illness and then they develop type 1 after that. So this one, the pancreas stops producing insulin. Due to the lack of insulin, then the cells can't use the glucose for energy, so fats are broken down, which produce ketones. As the sugar rises, the ketones in the body also rise, and then acidosis sets in. Symptoms of type 1 diabetes is increased thirst, frequent urination, bedwetting, nighttime waking, unintentional weight loss, and then behavior changes. Sometimes this is anger and anxiety. Sometimes this is extreme restlessness, like they just can't seem to pay attention in class. They can't seem to settle at bedtime. And then, of course, the fruity smelling breath. That's one of the big ones. When the ketones rise in the body, then DKA occurs, or diabetic ketoacidosis. Insulin is responsible for pushing the glucose into the cells. So when there's not enough insulin, the blood glucose rises and then fat is broken down for energy instead. When the fat is broken down, ketones occur. If left untreated, the buildup of ketones is what leads to DKA. When a patient is in DKA, they experience a cascade effect that includes dehydration, electrolyte imbalances, and metabolic acidosis. That's when we see those kids really looking kind of emaciated. These are kind of some of the signs and symptoms. They have really, really sunken dark eyes. Sometimes you might not notice anything else, but when they walk in the door, you just see that they just have such dark, deep bags underneath their eyes. And then the parents will talk about how they can't seem to quench their thirst. They're always asking for something to drink, even during the night, or they're getting up a lot during the night and they're going to the bathroom, or they're wetting the bed, even though they've been previously potty trained. Night waking is, I feel like, a really big one. You hear that a lot whenever they're discussing kids and having diabetes. And then, like I said before, behavior changes are a big one. Um, they go from normal, like happy kids in class, they become anxious and agitated, and then they start to be kind of lethargic and sleepy. And at the very end is when they kind of start vomiting, having diarrhea, or refusing to drink. I like these little graphics because it puts everything that we're looking for into one. So it's talking about how it says onset over 4 to 10 hours. Sometimes in the very beginning, when they're first diagnosed, it's a longer period of time because it just takes a little bit for the body to show those signs. So when the patient has a lack of insulin, they get with GI upset or febrile illness, then they begin to have increased insulin or increased glucose in the body and increased insulin needs. So they get that fruity smelling breath. They'll have tachycardia, hypotension. They'll get Kussmaul's. They'll be thirsty. Their blood sugar will rise above 240. And then we'll see the hyperkalemia. And then this discusses the high E, which is hydration, insulin, electrolyte replacement. That's what these patients that are in DKA need. When we're looking at lab values, the blood sugar is going to be high. Sometimes the machine here will read high, but sometimes their parents will catch them at home and it'll be 300 or 350 and they're still moving into the DKA. If they're a new onset diabetic, they won't know the ketones and such, but if they're a chronic diabetic, the parents will begin to check ketones at home, and they'll most likely come in and tell us that they have ketones in their urine. We'll see acidosis on a blood gas, so low pH below 7.3. CO2 will be low, potassium will be high initially, sodium will be low. What we're looking for, one of the major things we're looking for on the gas is the bicarb and the anion gap. So when we're talking about PDDK treatment and management, there's several needs, which is what we talked about in that last graphic, that we need to correct the fluid deficit, we need to fix the electrolyte imbalances, and we need to correct the acid-base status. So to do that, we treat based off of the patient's blood gas. We don't often use ABGs in pediatrics because it's super painful, and most of the time we can get what we need off of a VBG. If a patient is very, very sick, then they'll consider it, but I feel like the majority is used based off of venous. When DKA is confirmed based on that gas, 2 peripheral IV should be placed. This allows for us to run the 2-bag method, which is used in pediatrics, and it allows both sites to have the different types of fluids and insulin. We'll initiate hourly blood glucose monitoring. In the beginning, we may initiate it a little bit more often to make sure that we're not dropping the sugar too fast. And then IV insulin therapy. For UMC, our standard dose is 0.1 units per kg per hour. We don't bolus insulin in pediatrics. This is a big difference in adult DKA and pediatric DKA because we increase the risk of cerebral edema if we're bolusing insulin. And then, of course, we're going to initiate that 2-bag method. One of them has NS and then the electrolytes, and then the second one has dextrose and the electrolytes. So when we're discussing electrolytes in DKA, we have several that are pretty significant in every single patient. So initially, patients have hyperkalemia because the potassium that was in the intracellular space, it moves to the extracellular space, which increases that serum potassium. When we initiate IV insulin therapy, the potassium is pushed back into the cell, which then decreases the serum potassium. They also have low phosphate and low magnesium, and then we're watching that anion gap. The normal range is 0 to 15, and then this is how you calculate it based on the patient's labs. Cerebral edema is a big thing. I feel like in pediatrics, we really watch the neurostatus because of cerebral edema. This occurs from glucose shifting too quickly into the cells. So bolusing insulin can cause that. Decreasing the sugar by more than 150 can cause that. We really like to keep the patients in PO. We'll give them ice chips occasionally, but I feel like that's when they're in really mild DKA. We don't want to add any more fluid, especially when they're as thirsty as they are. So it's really important to teach the families to please do not feed or give the patient any fluids at that time, unless the physician orders that. And then, of course, hourly requirements are those blood sugar checks and neuro checks. I'm sorry. We want to make sure there's no neuro deficits related to cerebral edema. If you notice a neuro change in these pediatric patients, we should notify the provider pretty quickly so they can increase the monitoring and take a look at the patient and make sure nothing else is going on. This is the UMC DKA protocol. It's kind of everything that you would possibly need in a well DKA to a very, very sick DKA. We have our insulin protocols based on weight. We have our respiratory things like our blood gases, oxygen, dietitian. There's multiple things here that I feel like are important. They're labs and stuff. Most of the time we'll do serial labs. The most important thing here, though, is our fluids. We have several options for fluids, and the provider is the one that chooses one. But fluid 1 is always NS, fluid 2 is always D10. There's never anything different. Those do have extra electrolytes in them, which I'll show in just a second. And then, of course, we have our insulin. Here at UMC, we do different concentrations based on weight. And then that started still at the same rate. So when we're starting insulin, there are several big things that are super important. After spiking the insulin, the tubing has to be primed with 20 mils of insulin. The insulin is absorbed into the IV tubing. So if we don't do that, then the patient does not see as good effects of the insulin. So it seems like wasting, but it really matters when that tubing is coated. That initial 20 mils is just discarded as waste. We usually use a line cup, like a medicine cup or something, to ensure that we're wasting enough. But even our orders from pharmacy come back and remind us to do that. When the patient is getting insulin, we should make sure that no other insulin is given. And if it is ordered, like a sub-Q insulin is ordered, we should notify the provider and ask them if they want that. Definitely question an order when there's multiple insulins ordered. So our order, the standard insulin dose is 0.1 units per kg per hour. And then insulin is not ordered titratable, not here anyway. Whatever the physician orders it at is the rate that we keep it at. When we consider two-bag method, like I said, our fluid 1 is always our NS and our fluid 2 is always the D10. Unless NS is running until the sugar is less than 150, or unless the sugar is less than 150. Dextrose is not started until the sugar is less than 350. This just prevents us from decreasing the blood sugar too fast, too quickly. Whenever the physician is ordering the fluids, they're adding all of this. So it comes to us pre-made, but it has the potassium, chloride, and phosphate in both bags, and that's based on the patient's clinical weight. So we want to make sure that we have an accurate weight on the patient prior to all this being ordered. When we're calculating the rates based on the blood sugar, there will be a total fluid ordered by the provider. So if it's 150, then we'll calculate each one of these 100%, 50%, 25%, and so that each one of these is pre-known. So as we're checking the sugar every hour, we can adjust the fluids as needed. Like I said, the insulin never changes. It stays at the same titratable or the non-titratable rate. So this is an example with a total fluid ordered rate. So if 200 is our total ordered fluid, while the sugar is greater than 350, we keep that initial NS at 200, and then it goes down from there. Once our sugar reaches 150, our dextrose is the only thing running, and so it's at the 200 mils. I like to tell my people, please write that out so that you know how much you're titrating based off of what your order is. You're not having to check it. We also have a non-DKA care set, which is for obviously patients that have high blood sugars but aren't in full DKA. Most of the time, as long as we can give them some fluids and get them back to eating and drinking appropriately, then they can go home. When we're transitioning from the two bag method to an injectable insulin, there's several things that we're looking at. So we're looking at labs and the patient. And we want to make sure that our VBG is back within normal range, that the anion gap is closed, and that the patient is alert and oriented. If the patient has any neurodeficit, I think they will wait and see, even if they're leaving the patient on the two bag for a little bit longer, and wait till the patient converts and is back to being completely alert and oriented. Insulin coverage for pediatrics is based on carbs and pre-meal blood sugar. Often sliding scale is used, but I would say take caution with the first meal. Usually after being NPO, the patients feel super, super hungry, so they think that they're going to eat the whole plate, and then they don't consume as many carbs as we anticipate. So we've covered for a certain amount of carbs, and then now they haven't eaten it, and so we'll drop them a little bit too quickly. Usually, or sometimes, should say, we wait to insulin dose till after they eat for the very first one. And then obviously closely monitor the sugar. This is our diabetes education documentation, which is how we teach the patients. There are several pages to it, but I think the most important one is the sick day rules. Teaching with these patients has to begin at admission. When they come into the ER and we're recognizing these symptoms and we're first diagnosing them, it's very hard for them to, I guess, fathom and understand everything. So the more we teach them, the more we reinforce all of these things, the better understanding that they will have when they go home. So as we're doing things, as we're going through things, as we're starting things, if we're teaching the patients and we're telling them what's important to watch for, then they'll be able to, recognize it and hear it a little bit easier. I really like this and the sick day management care plan, because this allows the family to know when to check for ketones and what happens if the ketones are negative or if they're present. I think the most important thing about teaching is they have to have insulin even when they're sick, which seems opposite of what we would normally think. You would think if the patient is sick, their blood sugar is going to go down, but in these patients that don't produce insulin at all, like the type 1 diabetes patients, their sugar continues to rise even if they're sick, because it's not dependent on what they're eating, it's dependent on their pancreas secreting insulin, which it doesn't do. This is our home insulin dosing protocol. This is where the physicians can put how many units of insulin prior to the meals, and then how many grams of carbs is per how many insulin units. And then, of course, the sliding scale based on the sugar. When should blood sugar be addressed in these patients? They should check their blood sugar before a meal, 2 hours after the first bite, and then before bed. And then once they're controlled, in the nighttime blood sugar should be obtained around 0200 to make sure that we don't have any lows or any super highs during the night. So the next portion of this presentation, Cassidy so kindly put together for us. I'm going to go over it because she is not here today. But these are kind of some adult considerations. You'll see some very similar things, but there's quite a bit that's a little bit different from pediatrics as well. So one of the big things in adults is called ketogenesis. It's the same, it's similar to in pediatrics, but it occurs because the insulin there's not enough insulin present to produce or to block the glycerol and the fatty acid change from entering the cells. So then when those are taken to the liver to supply the body's energy demands, ketones are created. And then once they're released into the bloodstream, they're acidic, so then ketoacidosis occurs. It's hard on the kidneys because the kidneys have a hard time filtering those ketones because they're super large molecules. This is one reason that monitoring the patient's kidney statuses is really important, because the more they go into DKA and the more that the body has to try to filter the kidneys, there's a higher increased risk of something happening or to having kidney damage. Signs and symptoms in an adult is very similar. Nausea, vomiting, and abdominal pain, weight loss, polyuria, polydipsia, too small respirations, disorientation, acetone breath, and dysarrhythmias. I would say in in adult patients, disorientation is more commonly seen. I feel like most of these patients know that they should be checking their blood sugar, and they either don't feel like it or they're not feeling well. And so they get to a point where they're just too far gone, and then now they're disoriented and they're having a hard time controlling their sugars themselves. And then sometimes it takes a little bit for somebody to notice, and then it's this whole vicious cycle. When an adult patient gets hypokalemic, we can also see dysarrhythmias. So some common causes for adult patients are eyes, and as you can see here, infection, intoxication, insufficient insulin administration, ischemia, like a stroke or heart attack, and then any illness. These are all stressors on the bodies, which can make the patient go into DKA. Most of these are the same for pediatrics. Any type of infection, any type of viral illness, anything like that can cause this patients to go into DKA. So some diagnostic testing, this is very similar. We'll see some electrolyte changes on our ECG. We'll do serum glucoses, looking for those electrolytes. ABGs are a lot more common in adults. And then our normal electrolytes like our BUN and creatinine, our anion gap, looking at an actual EKG. And then any other studies that are compared or that are questioning what is going on. So if the patient has abdominal pain, they may do a CT or an ultrasound or something to rule out that as well. If the patient is in DKA, it's going to be very, very similar to what we did in pediatrics, but we're looking at that anion gap. That is what's monitoring our acid in our blood, and so as these things change, we're going to see more and more electrolyte changes and ABG, BBG changes in these patients. When ordering insulin for adults, it looks a little bit different. They have similar ordering plans, but it's for DKA versus non-DKA. One of the big things is we don't ever stop insulin therapy or insulin drip on any patients because we want to make sure that we're completing therapy versus kind of stopping and starting it. When we're treating DKA in adults, it's similar. So IV fluid therapy to create or to restore fluid volumes. Some of these patients have hypotension. We want to bring down those glucose levels and then correct our electrolyte imbalances. And then administer insulin. We always administer insulin on an IV pump, and then electrolyte replacement and monitoring, also on an IV pump. We're monitoring the same things, our potassium, our phosphorus, and our sodium. And then sometimes they'll administer sodium bicarb if the adult patient is super acidotic. When considering IV fluids in adult patients, lactated ringer and normal saline is usually kind of like our fluid one. The difference is they don't start them at the same time. So our lactated ringer and our normal saline are started until the patient's blood sugar gets below 250. When the blood sugar reaches 250 or it's less than 250, then they'll move to D5LR to kind of do the same thing as we talked about in pediatrics. We don't want to drop that blood sugar too quickly, but we want to help get the patient to a point where we can transition to that sub-Q insulin, which is what they'll be going home on. Before starting these drips, we're going to discontinue all other diabetic medications. Most of the time in adult patients, they already know that they're diabetic, and so they'll have a home regimen. Whenever we're triaging the patient or whenever we're assuming care as the primary nurse, we should be asking when is the last time they had their medications or what they took prior to coming in, or what led up to the fact or them having high blood sugars. You want to check the patient's potassium levels. We know that insulin decreases that potassium level, and so if the patient's potassium is less than 3.5, we want to hold until a potassium replacement can be initiated. And then verifying the patient's weight. Just like in a pediatric patient, an adult weight is still very important. We should make sure that we're actually physically weighing them versus using an estimated weight or a stated weight. For the UMC adult protocol, there's an IV bolus of insulin given prior to starting the actual insulin drip, which is 0.15 units per kg. If the patient weighs more than 150 kilos, then we have to discuss with the provider because the dosage is going to change just a little bit. This is an example of what the protocol here looks like. So if the initial bolus would be 11 units if the patient weighed 74 kilograms, and it's based off of this table and the patient's weight. When we're giving an IV push of insulin for these adult patients, we drop the insulin just like you would in normal units with an insulin syringe. The dose is verified with another RN, and then it's diluted into an NS flush, and then it's given to the patient. I think this is one thing that's super important when you're considering kind of going back to the potassium is making sure that that level is there and that it's confirmed with the physician. They know what it is, because we don't want to give a push dose of insulin and start an insulin drip if the patient's potassium is already low, because then we're going to see the changes in their rhythm and everything like that. So when we begin insulin, we're going to verify our order, ensure that we have our insulin from pharmacy. The standard concentration here is 100 units and 100 mils, making it 1 unit per mil. There is that change in pediatrics for the patients that are less than 20 kilos, but the standard concentration is the 100 units per 100 units. We'll calculate the initial dose of insulin and give that to the patient, and then we'll start our insulin infusion at 0.1 units per kg per hour, which on this 75 kilo patient is 7.5 units. These patients that are on DKA protocol that are receiving insulin, they're going to be going to the ICU. Here in our facility, any patient that is considered ICU status is accompanied by an RN for anything, whether that's diagnostic studies or anything like that, the nurse should go. We also have these patients on transport monitors or continuous cardiac monitoring at all times. When we're giving insulin, blood sugar should still be checked, just as the same as a pediatrics, at least hourly, if not more. We want to see a decrease of 50 to 100 milligrams per deciliter. If it decreases by more than 150, then there is a protocol for titrating the insulin for adults. So the initial decrease is lowering the insulin rate by 50%, notifying the provider. Once the sugar is less than 250, then the insulin is decreased to 0.05 units per kg per hour to try to keep that sugar between 120 and 250. As the glucose gets towards 120 or below 120, then we notify our admitting team. There's a hypoglycemia protocol as well, so that if the sugar reaches 70 or below, then we have something to combat that with. Anytime we have major changes in the patient's blood sugar, we should be notifying our providers. That way we can change the protocols or the orders based on what the patient actually needs. There's some do's and don'ts when considering adjusting insulin. So we're still checking the sugar even if it's in target. We're using finger sticks. We can use art lines. We can use central lines. And then, of course, decreasing, we want to see that 50 to 100 per hour. We're going to change that rate when the blood sugar is less than 250, and then document any changes. And then if there's any serum glucoses that go the opposite way, so they go back greater than 450, then we're going to send one to lab instead of just relying on the finger stick. We don't want to draw any of our labs from our dextrose or our TPN line. That's going to increase the concentration of the sugar in the blood from the line. And so it may give us a false high, which obviously would result in us creating a hypoglycemia situation. We don't want to drop the sugar greater than 150, and we don't want to abruptly stop the drip. When the patient's blood sugar drops below 250, that's when we stop our fluid 1 or our lactated ringer NS, and we start the D5 LR. That way we are supporting that sugar and keeping it from dropping too quickly. In adult patients, they begin sub-Q insulin 2 hours prior to stopping the insulin drip to help the patient's body adjust. The continued care and monitoring for all patients, especially adult patients, or in this situation, adult patients, is hourly glucose checks, strict intake and output, urine ketones, monitoring those, monitoring our ABGs, looking for our anion GLAP. If we have 3 measurements of less than 12, and then ECG and cardiac monitoring to monitor for dysarrhythmias. And then if there's any treatment complications, then we kind of cater to those. So we just change up what we're doing a little bit to help prevent these things. So like hypoglycemia, cerebral edema, pulmonary congestion. Obviously this patient, like I said, needs to go to the ICU. Whenever we're using the adult protocol to transition to sub-Q insulin, the transition starts 2 hours prior to discontinuing the drip. You have your physician's orders. You calculate the total daily insulin. We administer our long-acting insulin and then your short-acting insulin. At this point, whenever we obtain the initial physician order, most of the patient's electrolytes and everything should be normalized. The patient should not be having symptoms anymore. They should be kind of back to their normal self. Whenever they're calculating the total daily insulin, we're going to take the average rate over the last 8 hours in units per hour, and then by 24 hours. So if they've had 4 units per hour, then their total daily insulin for the last 24 hours is 96. And then, of course, our long-acting insulins are insulins that aren't going to act right now. They're going to be the ones that act overnight. And then our short-acting is for our meals and everything. If the patient is NPO, we want to hold that short-acting because we don't want to drop them. By that point, when we're transitioning, the patient should begin to be able to eat on a dietary plan, and so we should be able to get that. When we're discussing home considerations and teaching needs, I think teaching to the family and to the patient is super important. Knowing when to check the blood sugar at home, what sites they can use, how to count carbs, how to look at the labels on foods and to be able to count carbs appropriately, knowing what the sliding scale insulin is, symptoms of hypoglycemia, symptoms of hyperglycemia, all the supplies they'll need, and then any sick day needs. One teaching point that I think is super important is discussing glucagon with patients. We had a patient quite a while ago, but that the family came in and they were talking about how the patient's blood sugar was really high. When we got into discussing with the family, they just kept saying nothing that we do makes the patient the sugar low. Nothing that we do makes the patient sugar low. Turns out they were giving insulin, but they thought that when the patient's blood sugar is high, that they were supposed to give the glucagon. So they were giving the 10 units of insulin and they were also giving the patient the glucagon. And so, of course, like it was working against each other and not working. So I said this earlier, but teaching is really important and should begin at diagnosis. Even for recurrent visits where, you know, that sugar is high or the patient's in DKA. When they walk in the door, we should start talking to them about what the effects of high blood sugar is or what they should be doing at home or how to combat DKA when they're at home or when the patient's at school or when the patient doesn't feel like doing it or when they're sad or when they're upset, because all of those things affect that patient. I think talking about hypoglycemia to them is super important so that the patient, when the patient starts recognizing that they're feeling these things, and they can go ahead and treat before they get super hypoglycemic. I really like the acronym TIRED, tachycardia, irritability, restlessness, excessive hunger, and diaphoresis or depression. Knowing these things, and as a parent, it is really helpful to watch and make sure that the patient is not getting hypoglycemic. We've all seen a hypoglycemic patient that's super anxious and sweaty or confused or shaky. But not all pediatric patients get to that symptoms before their sugar is really, really low. Sometimes it's just the irritability comes on first. And these parents that have had a diabetic child for a while will start to recognize that. And so it's easier for us as healthcare professionals if we recognize things like irritability as a symptom to be able to catch that faster. Glucose control is super important on these sick days, like I discussed earlier. Insulin is always necessary. Their body does not produce it, so they have to have insulin. We can encourage them to check the urine ketones when they're sick and vomiting. If the blood sugar is greater than 300 or greater than 250 after 2 readings, then they should start to check. Moderate to large needs more insulin. And they can repeat that insulin every 2 to 4 hours until the blood sugar is lower or the ketones fall below moderate. If those ketones continue to rise or they get to large, despite adequate fluid resuscitation, adequate insulin administration, then the patient and they're experiencing other symptoms, and the patient needs to come in and be seen. Fluid replacement is super important on sick days when the sugar falls below 200 and they're unable to eat, then they can get these sugar containing fluids. We obviously in moderation. They can sip on Coke, Sprite, juice, anything to kind of keep that sugar in a normal range, but not too high. And then it's 15 grams, approximately 1.5 or half to 1 cup of sugar-free liquid per hour is what we want to encourage. I think part of this, encouraging these mildly sugar things, encourages the family to recognize that they need insulin. They associate sugar with insulin, and so we're keeping the sugar in a normal range, but we also don't want to encourage us to go the opposite and drink 6 Cokes and then have the opposite effect, but just encouraging good things to help maintain that blood sugar. They're going to test their urine ketones at home. They're reported as negative, small, medium, or large. When they come in, we should document that in our triage note, and we should notify the physician of whatever the patient reports it as. Not all strips are exactly the same, but this is generally about how many ketones is in each small, medium, or small, moderate, or large category. And then, of course, treating hypoglycemia. I think this is important to start discussing in the ER, and then discuss throughout the hospital stay. So children less than 20 get 0.5 milligram, which is half a syringe, and then greater than 20, they get a full syringe. I think teaching the patient what the signs and symptoms of hypoglycemia and when to use the glucagon is important, because we want them to try to treat it other ways first, like having a little bit of milk or having some juice or having some longer acting, you want short acting carbs in the moment, and then getting something else to help hold that sugar up. And then, of course, when should we seek emergency care? That's prolonged vomiting and diarrhea, not drinking any fluids, lethargy, that rapid Kussmaul, deep breathing, the fruity smelling breath, any signs of dehydration, persistent hyperglycemia that can't be treated with obviously the short acting insulin, and then ketones in the urine. Last but not least, diabetes is not a disease. It is a lifelong condition, but these patients with an individualized plan, whether a child or adult, they can live a full normal life. They have considerations with like running and heavy exercise, but the important thing to teach the parent is like, this kiddo's life is not over. In that same breath, though, their life is not over, but if you do not manage this appropriately, many not great things can come about with eyes and kidneys and hearts. We want to teach them along the way how important it is to manage this so that the patient lives an appropriate life and can do all the things that they want to do. Any questions?
I have a question.
Yeah.
For your pediatric protocol, do you guys run that 0 to 17 age, like technically quote quote pediatrics, or is there a different age?
Honestly, I feel like it's provider dependent. Most of the time it is. Any pediatric patient can follow this protocol. But I have seen where we've had really big patients, like 150 kilo patients or 100 kilo patients, where they transition to the adult protocol because they're an adult size patient. You know what I'm saying? So I feel
Yeah.
like it can really be used on any size patient, but it's going to be dependent on that provider.
Okay. And then I was trying to catch pictures of some of the sides. Is there any way you can share the PowerPoint
Sure,
at the end? Okay, thank
absolutely.
you.
Great questions. Anybody else have anything? I appreciate everybody being here. I'll give you a little bit of time back today. I know that pediatrics can be very, I don't know what to say, intimidating sometimes. And there are multiple things that are different, but these kids are lovely, and even when they're screaming and crying. And I appreciate you guys all willing to learn and to be present for some pediatric specific teaching and just being here with me this morning. So I do appreciate all of you being here.
Thank you, Jamie. And if you guys think of any questions after the fact, you're welcome to email Jamie or me or put it in the chat and we'll try to get them answered for you. I will post the link to the evaluation in the chat. And once you complete those, I will get your certificates distributed to you this week. Thank you again, Jamie, and thank you all for bearing with us over the past week to handle some technical issues, and we really appreciate you joining us this morning. If you have an email you would like the presentation sent to, please add that in the chat and Jamie and I can get those presentations to you. Thank you again.